Hello, everyone. So, today we'll do a bit of obstetrics. We'll talk about preterm labor and PPROM, which stands for preterm premature rupture of membranes. So, as you can see in the picture, that's a preterm baby. I'll talk about what preterm is in terms of the weeks of gestation and some of the complications. So, these are the objectives. We'll talk about definition of labor and classification of what makes it term, what makes it preterm, and the subclassifications of term and preterm. Some of the risk factors of preterm delivery, diagnosis, predictors of preterm labor, how we prevent preterm labor, complications, markers of fetal lung maturity, because one of the main problems of preterm labor is that the baby's lungs are not yet mature, so breathing becomes a problem. So there are certain markers of lung maturity that help you determine whether the baby is ready to be delivered or not. Management of preterm labor, and then preterm premature rupture of membranes, what it means, how you diagnose, and how you manage. Okay, so the definition of, we'll talk about labor first. So labor is a physiological process that involves uterine contractions that lead to expulsion of products of conception from the uterus out through the vagina. So products of conception can be anything, can be a live fetus, can be a stillbirth, can be a pre-viable fetus, which means that it hasn't yet matured, it hasn't reached 28 weeks. It's also part of the placenta. All of them fall under the products of conception. So there is false labor and true labor. What makes it true labor is when the uterine contractions increase in intensity and frequency, and importantly, leads to cervical changes, which means the dilatation and shortening of the cervix and fetal descent. So true labor is only when the cervix changes because of the pains and the fetus is constantly descending through the pelvic cavity into and out of the vagina. So term, what term usually when we think of term is when the baby is mature, ready to be delivered. So term starts at 37 weeks technically. So 37 to 38 weeks, 38 plus 6 days, it's early term. It's term but early term. 39 to 40 plus 6 days is now full term. That's the ideal delivery gestation. 41 to 41 plus 6 is late term. So after 42 weeks, that means it's post term, or as we call it, post datism. That means that the baby is now beyond the normal gestation period of a human being. So now, if from 37 weeks it's term, that means below 37 weeks it should be preterm. So we start from below 34 to 37 weeks, it's late preterm. 32 through 34 weeks is moderately preterm. 28 to 32 is very preterm, and less than 28 is extremely preterm. So less than 28 weeks usually, Kenya says that viability of a fetus, which means viability, which means that the chances of the fetus being alive uh, start at 28 weeks. But in other countries, more developed nations, it starts at 24 weeks. So basically, the chances of baby surviving after below 28 weeks are very low for obvious reasons, mainly lung immaturity, and they have also other complications, infections, and whatnot. So, of note, we usually deliver in Kenya by cesarean section any baby between 28 and 32. It's we don't risk labor because of any risk of prolongation of that labor will put the already critical fetus into a more critical state. Okay, so we'll talk about what the risk factors of preterm labor. Like ideally, a mother should deliver between 37 and 41 weeks. That's the normal. So there must be something that makes it earlier. So something abnormal that makes the delivery abnormal. So the risk factors are divided into maternal and pregnancy related. So maternal are to do with the mother even before pregnancy. So if she has a previous history of preterm, It's interesting that whenever you have a previous history of preterm, the likelihood of the next delivery being preterm is high, much higher than the normal population. Infections. Infections are very high, high fact, especially in the developing countries. When you get infected, the cytokines, especially interleukin 1, 6, 8, and tumor necrosis factor alpha, are high in your blood, and they trigger uterine contractions. So the contractions can come earlier than 37 weeks. Idiopathic is one of the main causes of preterm labor. We don't know the reason. Extremes of age, because of the weakness of the uterus. Very teenage pregnancies have a likelihood of being delivered preterm because the uterus is not strong enough to hold the baby, so it starts contracting and wanting to expel the fetus earlier. Same for older patients where the uterus again is weakened. Short maternal height, because if the mother's height is very short and the uterus is big, there can be an increased compression of the uterus just because of the physics of the height. So the increased pressure on the uterus can cause early labor. Comorbidities. Any mother with any other disease together with a pregnancy, or diabetes, pressure, like anything at all, it's a risk factor for preterm labor. Maternal stress, because as we know that cortisol is a stress hormone, and cortisol, once you have high levels of cortisol, it stimulates the placenta and the fetal membranes to produce prostaglandins. And prostaglandins are a potent contractor of the uterus. They trigger uterine contractions, in other words. Artificial reproductive techniques, the main reason why this one is a risk factor for preterm labor is because ARTs, which are artificial reproductive techniques, usually lead to multiple gestation. So anyone undergoing ART, they usually put many embryos in the womb so that if some of them die off, we have at least one or two viable remaining. So sometimes you have three or four or two, all of them reaching viability, so leading to multiple gestation. And because of multiple gestation, the uterus obviously will be bigger because there are more than one babies, and because of the increased stretching of the uterus, likely to contract earlier. Fibroids, again, same concept. Uterus will be bigger. Together with the baby inside, there'll be increased pressure, increased stretching, causing contractions, earlier contractions. Pregnancy related, I've talked about multiple gestation. Polyhydramnios is when there's a lot of amniotic fluid in the amniotic sac. Again, same concept, stretching the uterus. Macrosomia, which means big baby, usually seen in patients with gestational diabetes. Again, big baby stretches the uterus, earlier contractions. Antepartum hemorrhage is when you have bleeding after 37 weeks, or when you're term. No, after 28 weeks, sorry. After 28 weeks, when the baby is viable and you have bleeding, it's called antepartum hemorrhage. So, again, it's a risk factor. Anything that affects the well being of the fetus, the placenta, and the uterus can trigger contractions quicker. Preeclampsia, again, same concept. It's a comorbidity. It causes placental insufficiency. It can trigger preterm labor. So, how do you know this for sure? It's preterm labor. First of all, contractions. Contractions are the definition of labor. So, if you have uterine contractions, 4 contractions every 20 minutes or 8 contractions every 60 minutes, strong contractions, consistent, increasing in frequency and intensity, it's one of the diagnoses of preterm labor. And then cervical dilatation. As I said earlier, labor means contractions together with cervical changes. So cervical dilatation, if it's more than 3 centimeters and there's effacement. Effacement means shortening. Cervical length of less than 2.5. Cervical length usually should be more than 2.5 in normal patients. So if you do a transvaginal ultrasound and your length is less than 2.5, first of all, it's a risk factor for preterm labor, and it also falls under the criteria of the diagnosis of preterm labor. Fetal fibronectin in cervicovaginal fluid, if it's more than 50 nanograms. So FFN, as we say, fetal fibronectin, it's like a gluish substance which it's found between the placenta and the decidua. Decidua is the maternal, is the endometrium basically. So it kind of holds the placenta, it glues the placenta to the endometrium. So when it starts shedding, the glue starts shedding, that means labor is close. And usually it only happens after 37 weeks. So if you find fetal fibronectin in cervicovaginal fluids before 37 weeks, it's it's an indicator of preterm labor. And again, Bishop's score of more than 4, Bishop's score, it's a method of indicating how favorable a cervix is for labor. So there are various parameters. There is the cervical dilatation, effacement, position, station, and the consistency of the cervix, all of them, and then you score them. So if it's more than, usually if it's more than 6, that means the cervix is ripe and you can start augmenting labor. But in this case, when you diagnose preterm labor, you use the score of 4. Predictors of preterm labor, there is diagnosis and predictors. Predictors means that preterm labor hasn't yet occurred, but there's a very high likelihood that it will occur. So high levels of cytokines such as interleukin 168 and tumor necrosis factor alpha, as I said before, these are usually triggered by infections. So infection is one of the major reasons of preterm labor, because once these high levels of cytokines are in your blood and they reach the uterus, they can trigger contractions. Cervical funneling, U-shaped cervix. Usually a cervix is T-shaped, and the more it starts contracting and the effacement and the dilatation occurs, the shape of the cervix changes and it becomes U-shaped. Again, cervical length, same concept, and presence of fetal fibronectin. So if if you find FFN anytime between 22 and 37 weeks, that means that labor is about to occur and that's abnormal. So after 37 weeks is normal, before below 22 weeks is normal, but between 22 and 37 it's abnormal to be found in cervicovaginal fluids. Now, prevention of preterm labor, that means you have risk factors, you have predictors, but preterm labor hasn't yet occurred. So how do we prevent it? Progesterones, because progesterones works opposite as opposite to oxytocin. So oxytocin causes uterine contractions, while progesterone will prevent uterine contractions. So anytime you are seeing a mom uh, who has the risk factors of preterm and likely to go into preterm labor, you can start progesterone. And cervical circlage, this basically means circlage means you put a stitch around the cervix, you circle the cervix with a stitch, make it tighter. This one is usually seen in cervical incompetency. So when you have a mother with a history of miscarriages, especially in the second trimester, history of miscarriages, especially in the second trimester, means that the cervix is weak. It can't hold the weight of the baby, so it dilates before its time and the baby is expelled. Usually called miscarriage if it happens in the second trimester. So the way to prevent this in future pregnancies is there's a stitch that you put around the cervix. One of them is the McDonald stitch that you go around anti-clockwise around around the cervical os, and then you tie a knot either in the 12 o'clock or 6 o'clock position. Usually you do it in the 13th week of pregnancy, and around 37 weeks you come and you remove the stitch so that now the mom is ready to deliver and she's already held the baby for 37 weeks. So that one is a removable stitch. And then there's a Shirotka one, that is you go and bury it under the vaginal mucosa and you circle the cervix again, but this one is permanent. So once you put it in, it doesn't go out. So the only way to deliver is via C-section. So complications of preterm labor, the main one is respiratory distress syndrome. This is because the lungs don't have surfactant. Surfactant is an important part of the alveoli. It makes the alveoli, it keeps them patent, it keeps them open because as you know in physics there's surface tension. So the alveoli are aligned with fluid, and wherever there is fluid, there is surface tension. And if the surface tension is high, the alveoli can collapse. So the lung has some cells, the alveolar type 2 cells, which produce surfactant. And surfactant usually reduces the surface tension so that that pressure on the alveoli reduces and the alveoli can remain open for gas exchange. So when you deliver a baby before the lungs are mature, usually maturation occurs at 34 weeks and it continues. So the more you can delay labor, the better, allowing the fetal lungs to mature through production of enough surfactant. So if you don't have surfactant, the surface tension is uncontrolled, the alveoli collapse, causing respiratory distress syndrome. Another one is neonatal sepsis because already a baby's immune system is weakened, and if you deliver it even when the baby is more immature than normal, the immune system will be almost non existent and is very susceptible to infections. So, neonatal sepsis. And then there's retinopathy of immaturity, which means that usually uh, when babies are born earlier, they're on oxygen because of RDS, and because of that oxygen, it causes proliferative retinopathy because usually the retinopathy, the vessels in the retina start to grow haphazardly and uncontrollably, and that can lead to blindness. So there are many complications of immaturity, but these are the three main ones. Now we'll talk about a bit about the main one, which is the RDS. So fetal lung matures at 34 weeks. So it's not completely mature at 34 weeks, but at 34 weeks you can be sure that the surfactant has started being produced and the lung at least has a chance of survival when the baby is born. So surfactant is produced by alveolar type 2 cells, and the main component of surfactant is there are two, is phosphatidylcholine and phosphatidylglycerol. So the function, as I said, is to lower surface tension, allowing the alveoli to remain open. So now there is markers of fetal lung maturity. So let's say you have a pregnant mother with some complications, probably going to preterm labor. So she's around 34 weeks or past 34 weeks, and you want to confirm if the fetal lungs are mature. So what do you do? So there's one way is to look the amniotic fluid. You measure the levels of, you detect phosphatidylglycerol. The thing about phosphatidylglycerol, which is a component of surfactant, it's it's only present in amniotic fluid. And if it's present, it shows that surfactant is being produced. So you're a bit confident about the survival chances of the baby. Again, we have the lecithin sphingomyelin ratio. Again, surfactant is a lipid basically. So all these are tests of lipid in the amniotic fluid. There's amniotic fluid shake test, which is a bedside test. You just collect amniotic fluid in a bottle and then you shake it. If it starts to foam, that means there's lipids inside that. And the lipid that's usually inside amniotic fluid is surfactant. We have the Nile blue sulfate test, which tests for fetal cells in the amniotic fluid. Usually, when the baby is in the womb, some of the skin cells start shedding. So that's what we test. The Nile blue sulfate test checks for the fetal cells in the amniotic fluid. So usually, how this one works is when the baby produces surfactant in the lungs, because surfactant is a lipid. Usually, you also find it in the skin cells. So if more than 50% turns orange, that means surfactant is being produced. But the best test is the first one, phosphatidylglycerol in amniotic fluid. It's very sensitive and very specific. This is the shake test. As you can see, it starts to foam. That means there is presence of surfactant in the amniotic fluid. Now, management of preterm labor is when the contractions have begun before 37 weeks. So the first thing you should do is give corticosteroids, and corticosteroids help in production of surfactant, therefore help in fetal lung maturity. So you have a mother who's 35 weeks, 33 weeks, you're not sure about the lung maturity, you just give corticosteroids. Usually give 6 milligrams twice a day in intramuscular injections for 2 days. After 4 doses, you're more confident about fetal lung maturity. It's not written in stone that after 4 doses of dexamethasone, which is a corticosteroid, but the fetal lungs will be mature, but you have given the baby a better chance. Again, rectovaginal swab, because infections are one of the main causes of preterm labor, so you need to do a swab, do a microscopy and culture of the swab, and give antibiotics if infection is present. And then tocolysis. Tocolysis means toco means contractions and lysis means destroying. So destroying contraction. That means you're trying to stop contractions from happening. So there are some tocolysis agents which we'll look at in the next slide. But basically, there are three main components of management. There's corticosteroids for fetal lung maturity, rectovaginal swabs to rule out infections, and then delaying labor. So these are the drugs used for tocolysis. Calcium channel blockers, nifedipine is one of the most important and the safest drug that's used. Usually we use it as first line, followed by magnesium sulfate. So magnesium sulfate has two roles. It reduces uterine contraction as well as neuroprotection. It protects the baby's brain. Now we have beta agonists, which is salbutamol and ritodrine. Ritodrine is the main one that's used, but this one is unsafe because the maternal complications are high, especially pulmonary edema. Oxytocin antagonist. So oxytocin causes uterine contractions. You block it, no contractions. Atosiban is the oxytocin antagonist and it's very safe, especially in cardiac disease. And then we have prostaglandin synthesis inhibitor. Again, prostaglandin causes contractions. If you stop it, you don't get contractions. And indomethacin, it is an NSAID. It's used, but again, it's not very safe because as one of the big risk factors is persistent PDAs. I mean PDAs, patent ductus arteriosus, because usually prostaglandin is required to for the PDA to close, but if you give indomethacin, then it's likely to remain open. So PPROM, which is preterm premature rupture of membrane. So there are two things there is PROM and then there is PREPROM. PROM, which is premature rupture of membranes. Premature in terms of usually rupture of membranes occurs around active phase of labor when there are uterine contractions. That's normal rupture of membranes. Now, what makes it premature is when the membranes, which is the amniotic membranes, they rupture and fluid starts to drain out. Amniotic fluid starts to drain out before labor is set in. So now the mother is there draining liquor and she's not even in labor. That makes it prom. Now, what makes it preterm premature? Again, if that occurs before 37 weeks. So diagnosis is okay. The mom is draining something, so she's saying that maji menza kutoka. That means water start coming out. Now, how to make sure that this is amniotic? It can be two things. It can be amniotic fluid or it can be vaginal fluid due to an infection, which is vaginitis. So you do a nitrazine test. Nitrazine is a strip. It color changes based on the pH. So the pH of amniotic fluid is it's basic, so it will turn into blue. And for the vaginitis, for the vaginal fluid, it's acidic, so it will turn orange. So that's how you can determine what's what. And fun test, if you look at that, take that fluid, look at it under the microscope. If it's amniotic fluid, it will have a fun-like appearance because of high levels of estrogen in the amniotic fluid. Nile blue sulfate, same concept as before, will turn orange. That means that they are fetal cells, and fetal cells can only be found in amniotic fluid. So this is the nitrazine test. As I said, vaginal pH is acidic, so it will turn orange. However, if it's blue, that means it's amniotic fluid. This is the fun test. You see, it looks like fun. This is because of estrogen. Estrogen in the amniotic fluid. Now, management, it's simple. If it's before 34 weeks, that means fetal lungs are not yet mature, so you need to give corticosteroids and as well as delay labor. So corticosteroids plus tocolysis. The reason we do tocolysis is to allow the corticosteroids to work and to allow the fetal lungs to mature. And then antibiotics is routine and it's a must for any prom or PPROM, because once you start draining liquid, that means there is a connection between the outside and the baby inside. So there's a high likelihood for infections to travel inside, and the main risk of this is chorioamnionitis. So before 34 weeks, corticosteroid, tocolysis, antibiotics, and the rectovaginal swab. After 34 weeks, corticosteroids again. Just you can never be sure. Just give corticosteroids, but we don't do tocolysis anymore. We induce. We need the baby out as soon as possible before choriomnitis sets in. Again, antibiotics again, and rectovaginal swab. Thank you.